Good afternoon, friends, and thank you, Partho, for involving me in this particular IC. I think refractive surgery has seen the sea change in the last 30, 40 years. And looking into phakic IOLs, as he rightly said, is a concern for many, many patients. As Purinder talked about, there are various concerns on anatomical parameter of patient. The complications and problems can be associated with these things. So I would divide into two categories. One is intraoperative problems, which Dr. Ramamurthy talked about. In fact, he's made my talk more difficult because the presentations are almost similar, because complications, things will be almost same in these cases. The certain group of complications which are seen in an immediate post-op period or a later post-op period. So these are two important categories which you like to see. We have seen lenses can be chipped, because when you pull these lenses, you are not holding properly, the lens can tear. So these are important things not to damage. These are costly lenses. So always use a cotton applicator to remove the lens from the bottle so that you don't damage the thing. And hold the lens in a proper manner with a wider forceps so that pulling is better. If you hold a smaller edge, the tearing can happen in these cases. As Purinder nicely talked about, not to damage the lens, because that is the most important aspect of doing surgery in ICL, because your instrumentation can touch the lens thing. If you see here, this is 3.2 blade. Make sure you always use a new blade so you know the sharpness of blade and should not be going too far away. Therefore, the chamber should be filled with the viscoelastic if possible. If you do a side port first, then do a subsequent thing. If you look at the side port also, make sure it doesn't go beyond the pupillary margin. So these are two important tricks to be taken into consideration, not to damage the lens capsule. But once you damage the lens capsule, the entire surgical parameters are different in these cases. This, Dr. Ramamurthy talked about, filling the excessive viscoelastic in the anterior chamber can be a problem in these cases. The idea here is to keep injecting viscoelastic right from the edge. Don't take this cannula to 6 o'clock, which you normally do for cataract surgery. So that thing you have to avoid from your mind. It's not cataract surgery. It is an ICL surgery. Don't take this instrument far away and keep injecting from the wound area and let the aqueous be filling in this area. So you have some sort of reservoir aqueous there also, and doesn't make the entire lens capsule very, very taut. Sometimes taut lens capsule, you can have damage happening in these cases. So I would show a few of the videos which I think you saw earlier also, how to manage these cases. So this is one particular case where ICL was, got stuck in the wound area. If you see here, I'm withdrawing my applicator. The portion of ICL is stuck there. What to do then? In such cases, gentle tucking in the middle of ICL will open this lens. Rather than trying to re-push the entire thing, if you push it, then you can damage the structure here. So gentle pulling and gentle managing the central part of the lens will make sure that it will open. This is a second-hand utilization for unfolding the lens. If you see this particular lens, this is getting unfolded very slowly. This is happening because I use normally 1% sodium hyaluronate in all my cases. So this is trying to see a reverse unfolding here. You can see this flap is going this side. So this instrument will be very, very helpful here. If you tuck it here, the lens will open very nicely. So your second hand should also be free to manipulate your case. Always make sure your hand is free so that you can manipulate. So that is how you can avoid a disaster happening in the antechamber. But if the lens opens reverse, never try to unfold or refold inside. Always take out this lens out. You can enlarge the incision a little bigger so that it comes out easily. Just lift the peripheral one haptic, then hold it, and you can just pull it. And go sideways with 2 jerks, the lens will fold, and subsequently you can take it out very nicely in these cases. The other complication can be, for a beginners, they don't have a proper depth appreciation in some cases where the pupil is too large. In those cases, the tucking should be very, very nicely done. Never take this instrument far away into behind the iris. Never try to lift the pupillary margin. That will damage the pupil as well as sometimes lens. Don't tuck it very harshly here. Sometimes you can touch the lens capsule there. So these are two important points to be noticed. Once you have tucked 2 haptics, when you are trying to tuck this one, always use the central part of the lens to get the lens to this side. Then the peripheral haptics will be visible. Then tuck these haptics. Don't try to pull the lens from the peripheral part of the haptics. Axis rotation, Dr. Ramamurthy talked about. I will not repeat this. The other important thing is the lenticular opacity. We all are worried. One of the most important questions from the patient is, would I get cataract once we have ICL because it's resting onto the posterior chamber? The incidence reported is around 5% in large series of cases in the last 30 years, which may be less with the newer generation lenses. But the causes can be a little bit of damage, manipulation difficulties, viscoelastic over the lens capsule, if you see in this particular case, or sometimes you do have an anterior lens capsule opacity happening because the bolt is very, very less. Anything less than 100 micron or 50 micron will have a higher chances of a lens opacity coming up. So these are patients should be under observation. If you feel the lenticular opacities are coming, maybe that's an indication for exchange of these lenses. The surgery you saw is very, very simple in these cases also. The IOL power calculation is simple as routine cases. So these patients would be a high myopic patient. You have to modify your formula to SRK2. And the removal, as you saw earlier, you can just remove the haptic here. Then subsequently, you can pull the entire haptic out forceps. This was a 2.2 incision. You require a little more pressure there by manual pulling, and you can do the complete surgery here. You can do a nice rhexis, and subsequently, you can complete surgery. As you see here, a phaco can be done. Normally, they are soft and nucleus sclerosis patients. Complete and lens implantation can be done in these cases. If you see, this is a multi-piece lens because this is expand series of lenses because most patients will have a high power requirement because of a high axle in these cases. As I said, the surgeon learning factor is important, not to damage the lens capsule. The patient factor, as we talked about, the bolt may be less, but sometimes you have made a compromise in the initial selection of patients. Your anterior chamber depths are not proper, you still went for the surgery, or your wide to wide measurement was not proper. So these are two important aspects of getting a poor bolting in your patients. There are other complications can be increased intraocular pressure subsequently because of peripheral pigment depositions, damage to the lens, and very high bolt causing a compromised angle in these patients and subsequently having glaucoma. So these are two, I think, important reasons. High bolt and inflammation is a cause for a secondary glaucoma in most patients. And they are myopic patients. So steroid-induced glaucoma is also very important in these patients. Don't use steroid more frequently, more often, more longer in these cases unless they require steroids. So if you look into these aspects, make sure if you have uncontrolled intraocular pressure, look for your PI may be blocked. You do a repeat PI. Still it's not under control. You may have to do a trabeculectomy if the medical treatment is not successful in these cases. The OBD removal has been shown by Dr. Partho, especially the new design B4 series. If you use Helon as a substitute, it comes out as a bolus through the main port itself. But still, you may have a little bit of viscoelastic underneath the lens, and that can be taken out by bimanual aspiration very simply because if you see here, this viscoelastic can be nicely aspirated just over you go up over the hole, and entire viscoelastic can be taken off. So this is a good innovation by STAR people to have a central hole, which also makes sure that you remove the viscoelastic totally, as well as it also help in aqueous circulation in these patients. Endothelial cell loss may happen in these patients. The reported endothelial cell loss around 3.7 to 4% in 4 years. Subsequently, it may not be that significant as a primary surgery. Other thing related to any intraocular surgery is infection, and it is true for our cases with ICL also. The rate may be very, very less, 1 in 8,000 or 1 in 6,000 cases. So this is one of my patients who developed severe inflammation, query endophthalmitis at day 7 of surgery with the initial 6/6 vision. So these are patients how to manage. Sometimes you may have to remove the ICL because that may be the factor for an infection in these patients. If you see here, the patient has a poor glow. I would remove the ICL first. The little hyperion is seen in this particular patient. The ICL is removed as you see in a routine cases. Just inject a viscoelastic underneath the ICL, lift the peripheral haptic of this, pull it out, put suture, and subsequently put intravitreal injection in this patient. And subsequently, the patient improved in a post-op period to a 6/6 vision with glasses next 3 months. And subsequently, I re-implanted the ICL in this patient to a 6/5 vision. So if you manage patient properly in right time, you can still save these patients also. So ICL explantation is one of the indications of if you have endorph in ICL patients. Glare and halos can happen, especially little decentered lenses, large pupil. The other concern is we had used very sized lenses earlier. People still use very sized in some places. The 3 major complications which we had seen was severe inflammation, dislocation of inclination area, and atrophy of iris happening in these patients. I think the largest and longest results been published by us during very sized lenses. 5-year results showed very little cases of high IOP. There's a chances of disinclination happening because of trauma. It can be spontaneous because of atrophy also. But if it is because trauma, you can still report it, but if it's a large atrophy, sometimes may be difficult to assess. Endothelial cell loss can be much more in these patients compared to ICL patients, but it is not very significant in our 5-year results. The initial drop is there in the first 6 months, around 6%. Subsequently, next 4 years, we have seen only 10% cell loss in these patients. So it's not that every patient will have a severe endothelial cell loss. You can still implant these lenses if you don't have other options. But yes, we have ICL as a good option these days. We don't really look into a very size because we don't get into foldable designs in our country. Dislocation of ICL can also happen. This is one of my patients with an injury to the face and the ICL haptic came off. So this can also happen ICL, not with very size only. So I would say complications do occur in any surgery, especially intraocular surgery. It's true for our phakic also, but fortunately they are very, very rare, and if managed properly, intraoperatively and postoperatively, and especially looking for a better examination and parameter finding of these patients, you can still do a very good job in these patients. Thank you for your kind listening.